Managing perforated gastric ulcer, a question and answer session. Diagnosis, surgical management, and post-operative care. Welcome to our podcast episode, where we thoroughly explore the critical aspects of managing a perforated gastric ulcer. In this session, we will address 100 essential questions, guiding you step by step through initial diagnosis, surgical intervention, post-operative care, and complex scenarios. Each question is prefaced by question, and each answer by answer. Diagnosis and initial presentation. Question: what is the classic clinical presentation of a perforated gastric ulcer? Answer: the classic presentation involves a sudden, severe, and catastrophic onset of pain in the upper abdomen that quickly becomes generalized due to leakage of gastric contents. The abdomen is rigid like a board, and systemic signs such as rapid heartbeat, rapid breathing, and fever indicate sepsis. Question: what are the key findings on physical examination? Answer: the patient typically appears distressed and avoids movement to lessen pain. There is widespread tenderness, abdominal rigidity, reduced or absent bowel sounds indicating paralysis, and signs of shock. A rare finding is Hammond's sign, which is a crunching sound over the heart. Rectal examination may reveal tenderness in the pouch of Douglas. Question: what is the most important initial imaging study? Answer: an erect chest X-ray is critical, with the classic finding being free air under the diaphragm, indicating pneumoperitoneum in most cases. Question: if an erect chest X-ray is not possible, what is the alternative? Answer: alternatives include a left lateral decubitus abdominal X-ray or, more commonly, a computed tomography scan of the abdomen and pelvis, which can detect small amounts of free air and localize the perforation. Question: what is the football sign on an X-ray? Answer: the football sign is a large, oval area of radiolucency in the mid-abdomen seen on a supine film, representing massive free air outlining the abdominal cavity. Question: what laboratory abnormalities are commonly seen? Answer: common findings include an increased white cell count, elevated pancreatic enzymes, and metabolic acidosis with raised lactate in advanced or septic shock. Question: what is the differential diagnosis for sudden onset of severe abdominal pain? Answer: the differential includes perforated ulcer, acute inflammation of the pancreas, ruptured abdominal aortic aneurysm, loss of blood supply to the intestines, acute inflammation of the gallbladder, and ruptured ectopic pregnancy. Question: why is a history of nonsteroidal anti-inflammatory drug use or Helicobacter pylori infection critical? Answer: these are the two leading causes of peptic ulcer disease resulting in perforation. The history guides long-term management strategies. Question: what is the significance of a history of heartburn or acid reflux disease? Answer: such a history may suggest underlying acid-related disease but is not specific. It helps differentiate a perforated ulcer from other causes. Question: how does the pain of a perforated ulcer differ from that of acute inflammation of the pancreas? Answer: pain from perforation is maximal at onset and the patient remains still, while pancreatitis pain builds gradually and patients often move restlessly. Question: what is the role of bedside ultrasound in the emergency department? Answer: bedside ultrasound can quickly detect free fluid and may show the curtain sign but is less sensitive for free air than computed tomography and depends on the operator. Question: what is the Bowie scoring system? Answer: the Bowie scoring system is a tool used before surgery to predict risk in patients with perforated peptic ulcers. Points are given for major illness, shock before surgery, and duration of perforation over 24 hours. A higher score predicts greater risk of complications and death. Question: what is the significance of symptoms lasting more than 24 hours? Answer: prolonged symptoms are linked to higher rates of septic complications and death and are a component of the Bowie score, often indicating severe peritonitis. Question: what immediate interventions are required before surgery? Answer: interventions include intravenous fluid resuscitation, broad-spectrum intravenous antibiotics, placement of a nasogastric tube, and correction of blood clotting and electrolyte abnormalities. Question: why are intravenous antibiotics given before surgery? Answer: they are administered to treat contamination from stomach and intestinal bacteria, which includes both aerobic and anaerobic organisms. Question: what is the primary goal of surgical management? Answer: the main goal is source control, closing the perforation, stopping further contamination, and thoroughly washing the abdominal cavity. Question: when might non-operative management be considered? Answer: Non-operative management may be considered in rare cases where the patient is stable, non-septic, and the perforation is sealed and localized, as confirmed by contrast studies. Question: what diagnostic test can confirm a sealed perforation? Answer: A. Water-soluble contrast upper gastrointestinal series showing no leakage of contrast outside the stomach or duodenum confirms a sealed perforation. Question: what are absolute contraindications to non-operative management? Answer: these include unstable vital signs, widespread peritonitis, ongoing leak on contrast study, and immunosuppression. Question: what is the most common location for a duodenal ulcer to perforate? Answer: the first part of the duodenum on the anterior wall is the most common site. Preoperative management and resuscitation. Question: what two large-bore intravenous access lines are essential? Answer: two large-bore intravenous lines are essential for rapid administration of fluids and blood products in an unstable patient. Question: what type of fluid should be used for initial resuscitation? Answer: balanced crystalloid solutions such as lactated ringers or plasmolite are preferred. Normal saline can cause metabolic issues if used in large volumes. Question: when should medications to raise blood pressure be initiated? Answer: these should only be started after sufficient fluid resuscitation if the patient remains hypotensive, ensuring organ perfusion while avoiding fluid overload. Question: why is urinary catheterization important? Answer: it allows for monitoring urine output, which reflects organ perfusion and adequate resuscitation. The goal is greater than 0.5 milliliters per kilogram per hour. Question: what electrolyte imbalances are common during resuscitation? Answer: common imbalances include low potassium, magnesium, and calcium, which must be corrected to prevent heart rhythm disturbances. Question: what is the role of blood products? Answer: blood products are given for significant anemia or shock and plasma or platelets for blood clotting disorders. Question: should a patient receive a proton pump inhibitor before surgery? Answer: yes. Intravenous proton pump inhibitors are started to reduce acid production, although surgical repair is the definitive treatment. Question: what is the target mean arterial pressure during resuscitation? Answer: the target is over 65 millimeters of mercury to ensure adequate organ perfusion. Question: how is adequate resuscitation defined before surgery? Answer: adequate resuscitation is based on clinical improvements such as better mental status, stabilized vital signs, increased urine output, and reduced lactate levels. Question: what is the anesthesiologist's primary concern during induction? Answer: the main concern is aspiration of stomach contents due to a full stomach and bowel paralysis. Rapid sequence induction with pressure on the cricoid cartilage is standard. Operative management and techniques. Question: what is the standard incision for exploring a perforated ulcer? Answer: an upper midline incision provides the best access to the upper abdomen. Question: what are the key operative steps? Answer: the main steps are identifying the perforation, taking a biopsy for Helicobacter pylori, closing the perforation with an omental patch, and thoroughly irrigating the abdominal cavity. Question: what is an omental patch? Answer: an omental patch is the standard repair for most perforated duodenal ulcers, where a flap of the omentum is sutured over the perforation to seal it. Question: when is primary closure of a perforation considered? Answer: primary closure is considered for small, clean-edged gastric ulcers with little inflammation, but is less common due to fragile tissue. Question: what is the difference in managing gastric versus duodenal ulcer perforations? Answer: all gastric ulcers must be biopsied to rule out cancer, while duodenal ulcers are rarely malignant. Gastric ulcers may require more extensive surgery if cancer is suspected. Question: when is a definitive acid-reducing procedure indicated? Answer: such procedures are considered in stable, low-risk patients with a long history of ulcer disease and no prior medical treatment, but are less common now due to advances in medical therapy. Question: what are the types of vagotomy? Answer: types include truncal vagotomy, which requires a drainage procedure, selective vagotomy, and highly selective vagotomy, which preserves nerve supply to the pylorus. Question: what is a pyloroplasty? Answer: pyloroplasty is a surgical widening of the pylorus, often performed with a truncal vagotomy to aid gastric emptying. Question: when is an omental patch insufficient for a gastric ulcer? Answer: for large ulcers, fragile tissue, or suspected malignancy, a more extensive resection may be required. Question: what is the role of laparoscopic repair? Answer: Laparoscopic repair is suitable for stable patients with early presentation, offering less pain and faster recovery. Question: what are the contraindications to laparoscopic repair? Answer: contraindications include unstable vital signs, inability to tolerate abdominal insufflation, severe health conditions, and dense adhesions. Question: how is peritoneal lavage performed? Answer: lavage is performed with several liters of warm saline until the fluid returns clear, cleaning all abdominal spaces. Question: should drains be placed routinely? Answer: drains are not routinely placed for simple repairs but may be used if there is concern for ongoing leakage or a large abscess. Question: what is Taylor's method? Answer: Taylor's method is a non-operative historical approach involving continuous suction and intravenous antibiotics, rarely used today. Question: how do you handle a giant posterior gastric ulcer that has perforated? Answer: this complex situation often requires partial removal of the stomach, as patching is not feasible and cancer risk is high. Question: what is the cellar patch technique? Answer: this technique involves placing sutures laterally and tucking the omentum under them before tying, creating a secure seal. Question: why is it important to test the repair for leaks? Answer: testing ensures the seal is watertight, typically by instilling air or dye and observing for leakage. Question: what is the role of a feeding jejunostomy tube? Answer: in critically ill or malnourished patients, a feeding tube can be placed for early nutrition, bypassing the repaired stomach. Question: how is a suspected malignant gastric ulcer handled during surgery? Answer: suspicious ulcers are biopsied, and if cancer is confirmed, a more extensive removal with lymph node dissection is performed if the patient is stable. Question: what is the key principle behind an omental patch? Answer: the omentum promotes healing and forms a secure seal even on inflamed or non-viable tissue due to its rich blood supply and immune properties. Question: what is the most common intraoperative difficulty? Answer: identifying the exact site of perforation can be challenging due to severe inflammation and exudate, especially in the anterior first part of the duodenum. Question: what should you do if you find a perforated ulcer and another unexpected pathology? Answer: the life-threatening perforation should be addressed first, with the incidental finding managed simultaneously if the patient is stable, or postponed otherwise. Question: what is the risk of closing a large perforation under tension? Answer: closure under tension can lead to breakdown and leakage, a serious complication. Question: why is a maneuver to mobilize the duodenum performed? Answer: this maneuver provides better exposure for posterior ulcers or procedures to widen the pylorus. Question: what is a Billroth reconstruction? Answer: after removal of the lower part of the stomach, the duodenum is joined directly to the stomach. Question: what is a Billroth reconstruction? Answer: after removal of the lower stomach, the duodenal stump is closed and the stomach is joined to the small intestine. Question: what is the potential complication of a closed duodenal stump in Billroth 2? Answer: there is risk of stump blowout, leading to a fistula and peritonitis. Question: when is a tube placed in the duodenum considered? Answer: a tube may be placed when closing a difficult duodenal stump to prevent blowout and act as a controlled fistula. Question: what is the role of peritoneal cultures? Answer: peritoneal cultures are controversial and not routinely recommended for community-acquired perforations, but may be useful in hospital-acquired or recurrent infections. Question: how is the abdomen closed after a contaminated case? Answer: the fascia is closed with a running suture, and the skin is often left open or packed, with delayed closure to reduce infection risk. Postoperative management. Question: what is the expected postoperative course in the intensive care unit or ward? Answer: management includes continued intravenous fluids and antibiotics, nasogastric tube suction, nothing by mouth, and gradual diet advancement as bowel function returns. Question: how long should postoperative intravenous antibiotics continue? Answer: antibiotics are typically continued for 3 to 7 days or until the patient is afebrile, with a normal white count and resolved signs of sepsis. Question: when can the nasogastric tube be removed? Answer: the tube can be removed when output is minimal and changes from bilious to intestinal fluid, indicating bowel function return. Question: what is the diet advancement protocol? Answer: the protocol progresses from nothing by mouth to ice chips, clear liquids, full liquids, and finally a soft diet over several days. Question: what is the role of blood clot prevention after surgery? Answer: Preventing clot formation is critical due to increased risk from inflammation, immobility, and surgery, using medications and compression devices. Question: what are the key signs of an anastomotic leak? Answer: signs include unexplained rapid heartbeat, fever, increased white cell count, worsening abdominal pain, and abnormal drain output. Confirmation is done by computed tomography with oral contrast. Question: how is a postoperative leak managed? Answer: small contained leaks may be managed with drainage, nothing by mouth, nutritional support, and antibiotics. Large leaks with peritonitis require reoperation. Question: what is the most common cause of fever on postoperative days 1 to 2? Answer: the most common cause is collapse of lung tissue, managed with breathing exercises and mobilization. Question: what is the most common cause of fever on postoperative days 3 to 5? Answer: infection of the urinary tract is the most common cause. Question: what is the most common cause of fever on postoperative days 5 to 7? Answer: surgical site infection is the most common cause. Question: when should Helicobacter pylori eradication therapy be started? Answer: therapy should begin orally once the patient can tolerate a diet, using a proton pump inhibitor plus 2 antibiotics for 14 days. Question: how is Helicobacter pylori eradication confirmed? Answer: eradication is confirmed by a breath test or stool antigen test several weeks after completing therapy and stopping acid suppression. Question: what is the long-term management after recovery? Answer: treat the underlying cause with lifelong acid suppression if non-steroidal anti-inflammatory drugs cannot be stopped, or complete eradication of Helicobacter pylori followed by confirmation. Question: what is dumping syndrome and when does it occur? Answer: dumping syndrome is a complication of gastric surgery or nerve cutting. Early dumping causes fluid shifts and gastrointestinal symptoms shortly after meals. Late dumping is due to low blood sugar 2 to 3 hours after eating. Question: what is the management of a patient who continues to smoke? Answer: aggressive counseling to stop smoking is required, as smoking increases risk of ulcer recurrence and poor healing. Question: when can a patient be safely discharged? Answer: discharge is appropriate when the patient is afebrile, mobile, tolerating a soft diet, has controlled pain on oral medications, and a clean incision. Question: what is the role of stress ulcer prevention after recovery? Answer: prevention is lifelong if the cause persists, such as continued nonsteroidal anti-inflammatory drug use. Otherwise, it is only necessary during critical illness. Question: what is the most common long-term complication? Answer: recurrence of ulcers is the most common, significantly reduced by successful Helicobacter pylori eradication and avoidance of nonsteroidal anti-inflammatory drugs. Question: what is the role of follow-up endoscopy? Answer: follow-up endoscopy is mandatory for all gastric ulcer patients in 6 to 8 weeks to confirm healing and rule out cancer, even if initial biopsy was benign. Question: what is the mortality rate for a perforated peptic ulcer? Answer: mortality remains significant, ranging from 5 to 25%, depending on age, underlying health, and delay to surgery. Complications and special scenarios. Question: what is a subphrenic abscess? Answer: a subphrenic abscess is a collection of infected fluid between the liver and diaphragm, presenting with persistent fever, hiccups, and shoulder pain. Question: how is a subphrenic abscess diagnosed and treated? Answer: diagnosis is by computed tomography scan, and treatment is image-guided drainage and antibiotics. Question: what is a duodenal fistula and how is it managed? Answer: a duodenal fistula is an abnormal connection between the duodenum and the skin or another organ. Initial management is nothing by mouth, nutritional support, and control of output. Most close spontaneously, but surgery may be needed for persistent cases. Question: what is the most common cause of death following repair? Answer: the leading cause is multiple organ failure due to uncontrolled sepsis. Question: what is the seesaw sign in a duodenal fistula? Answer: the seesaw sign refers to high output from the fistula correlating with no output from the nasogastric tube and vice versa, due to preferential flow. Question: how do you manage a patient with a perforated ulcer and end-stage kidney disease? Answer: these patients require careful fluid and electrolyte management, avoidance of kidney-toxic antibiotics, and adjusted medication doses due to high risk. Question: how does management differ in an immunocompromised patient? Answer: there is a lower threshold for surgical intervention as classic signs may be absent, These patients are at greater risk for infection and poor healing. Question: what is the management of a perforated ulcer in a pregnant patient? Answer: it is an emergency requiring both surgical and obstetric management. Principles remain the same, with careful fetal monitoring and use of medications safe in pregnancy. Question: what is the differential for postoperative intra-abdominal bleeding? Answer: causes include bleeding from the suture line, slipped ligature, or a clotting disorder, managed with resuscitation, correction of clotting, and surgery if unstable. Question: what is the dumpling or rolled omentum technique? Answer: this technique is similar to an omental patch, but the omentum is rolled into a plug and sutured into the perforation. Question: what is the significance of finding Candida species in peritoneal fluid? Answer: fungal contamination may occur, but targeted antifungal therapy is not routinely recommended unless the patient is immunocompromised or has persistent sepsis. Question: what is the role of endoscopic retrograde cholangiopancreatography in a patient with a perforated ulcer and suspected bile duct stones? Answer: the ulcer takes priority. The procedure is deferred until after surgical control or performed in a hybrid operating room if necessary. Question: what is a gastrocolic fistula? Answer: a gastrocolic fistula is a rare complication where a chronic ulcer erodes into the colon, causing vomiting of fecal material and diarrhea, not typically a result of acute perforation. Question: how is a patient managed who perforates while on antiplatelet agents? Answer: urgent surgery is required, as the risk of bleeding and death from perforation outweighs the risk of clotting. Platelet transfusion may be needed if bleeding is a concern. Question: what is the double patch technique? Answer: this involves using a patch from the falciform ligament in addition to an omental patch for large or difficult closures. Question: what is the most common site for a marginal ulcer after bilrote 2? Answer: the most common site is at the connection between the stomach and the small intestine. Question: what is afferent loop syndrome after bilrote 2? Answer: afferent loop syndrome is an obstruction of the limb leading to the connection, causing pain and projectile vomiting of bile as a late complication. Question: what is the role of enteral nutrition versus total parenteral nutrition? Answer: enteral nutrition is preferred, even via tube, as it preserves gut function and reduces infection risk compared to intravenous feeding. Question: what is the triangle of doom in laparoscopic ulcer repair? Answer: while not a standard term, it refers to the importance of identifying and avoiding major blood vessels when placing sutures near the duodenum. Question: what is the single most important prognostic factor? Answer: time from perforation to surgery is the strongest predictor of survival and reduced complications, with early intervention being critical. Thank you for joining us in this comprehensive podcast. We hope this detailed question and answer session has provided valuable insights into the management of perforated gastric ulcers. If you enjoy the content, please like, share and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.